everybody. Welcome back to our series of podcasts that we call Menninger Mindscape. It's really great to have my guest today, Dr. Jon Allen, who you may know already because he is an interviewer on a parallel series, which is patient and family education interviews that we also do here at Menninger. Jon is a senior psychologist at Menninger and professor of psychiatry in our Department of Psychiatry at Baylor, and probably well known to many or most of you. Jon is an author and has written all kinds of things, and his areas of very special interest are in attachment and mentalization, other things related to that in terms of problems around depression and trauma. We're not necessarily going to focus on those today. We thought we'd have a little bit of a different conversation. Jon and I were in a meeting, and afterwards he stopped by and said, I just thought maybe we'll sit down and talk because I want to be sure we're not on different pages. And this came up when I was using the term brain disorders or psychiatric disorders to refer to mental illnesses, which is an older, more traditional term. And so Jon came by and said he had some thoughts about that. I'm going to let you say a little bit about that, and then we'll see where we go.
Okay, well, first, thanks very much for including me in this series and talking with me about this issue.
Yeah.
As you know, I feel quite passionately about it. Let me just be somewhat heretical and say that my concern is with biomania. By which I mean excessive enthusiasm for exclusively biological approaches to psychiatric disorder. And the brain disease thing, I'll be the first to say that these are physical illnesses. I've done a lot of patient education about trauma and about depression, written books for patients about them. I make a big deal that these are physical illnesses, and we need to take that seriously. No question about that. And my hope is that that will help patients mainly, as well as family members, be more patient with themselves for the difficulty recovering. Sometimes I think we use the term mental illness, the old terms. It's as if, well, this is a mental illness. Why don't you change your mind? As if you could do it by a force of will. So I think that's what people need to understand. The problem is that physical illness is one perspective, but not the only perspective.
Right. Well, yeah, see, and I really think that's important, and that's one of the reasons we thought it'd be a good idea to do this podcast and just have a little discussion about it. Because not one or the other. It's not just take your pick and it's either brain or the mind might be another way to refer to it. We have discussions about that all the time. I think it's very, very exciting, the just explosion of research in neuroscience and what we're learning. We're looking under the hood in a way that we never could do in the past and finding out enormously important things. As we were talking a minute ago, we now see neuroscience looking at the neurobiology of the unconscious and of things like the self. These are terms that came from theory, that came from decades ago. So they're very full circle, but now linking to neuroscience and neurobiology. So we know most of the illnesses that are labeled in the book, such as depression, such as post-traumatic stress disorder, even personality disorders, which is an area of my interest, have in fact neuropathology that's part of the illness. But we don't want to forget that there's a person there and that there is, as you've said, life that goes with it. Mm-hmm. And sometimes we get so focused on the neurobiology that it tempts us to kind of stay too far to one end. You said something when we were talking before about this, which I'd ask you to say a little bit about, because you said you worry that if we focus too much on neuroscience and neurobiology, it might make stigma worse. And,
yes.
And that was interesting to me because I often think that using the term brain disorders helps in terms of the stigma of mental illness.
Yes, and that was my thought exactly. And that's why when I came across a review, a meta-analysis of a lot of research on the relation between the labels we use and stigma. And to my chagrin, actually, having talked about physical illness, actually what I learned is that not only does the brain disease label not decrease stigma, in other words, it doesn't do what we thought. In other words, we could say, well, these are like general medical conditions. Why stigmatize something that's a general medical condition? But actually, it doesn't reduce stigma and actually may have a downside of increasing pessimism about prognosis and possibly also increasing perception of dangerousness, which would be, is obviously hugely relevant. So that's a worry I have, actually, that at worst, these labels may be backfiring at this point.
Yeah, well, that's a very interesting idea. I guess I would argue I think the jury's out on that. And again, I don't think there's going to be a single truth that we uncover. But I encounter, and I know you do, so often this residue of a belief that it's shameful somehow to say you have a mental illness. And the reasons are many, but among them are the idea that it reflects that you just don't have a backbone, that you're just spineless and you're a weakling, and you should be ashamed of yourself. You should sort of get it together and walk tall and stop sniveling.
Yes.
So that kind of attitude it's still very, very pervasive.
Yeah.
And that looks at mental illness as if somehow you were coddled when you were brought up, or you were, in fact, not in a healthy environment, and you should be able to rise above it. Again, as if it's some kind of weakness, rather than that this is no different than if you have a risk factor to develop diabetes or hypertension or heart disease, and we know that's exactly correct in terms of depression and bipolar disorder, schizophrenia, but other things. So our disorders are, in fact, similar to main physical conditions. There are risk factors and there is neuropathology. I think for many people that is destigmatizing. I think many people feel, oh, then I can hold my head up and not be ashamed to say I have this illness, which is no different than your illness, which you're always talking about and you don't hide at all. You take your hypertension pill in front of my eyes every day. So I still think that for many people that is helpful, but I hadn't thought about your point, which is that it could then lead to a feeling, well, it's sort of, I'm doomed. It's hopeless.
Exactly.
I won't be able to fix it.
Yeah, I'd like to say more about the no difference point, because I think this is really crucial. That the similarity, say with heart disease, is that you have the neuropathology or the cardiac pathology, but that pathology is very much intertwined with your life, how you live your life. I mean, we know that we've got a combination of biological risk, genetic risk, and life stress. I mean, we've known this for decades. So the mania part that I worry about is getting so enthusiastic, which we have good reason to be about the neuroscience, that we lose sight of the fact that your life plays a huge role in how your brain develops and functions. So, and of course, I'm a psychotherapist.
Right.
So I'm interested in the person's life and what they need to do in their life to affect their brain function.
Yeah.
That's the crucial thing, just as heart disease. Well, you keep smoking, drinking, eating too much, and you're rowing upstream in trying to work with your heart condition. I think it's no different, actually. one of my internists once said, he's not aware of a general medical condition that is not influenced by stress.
Yeah.
And I think it's basically the same point.
Well, go to primary care docs, go to family practitioners, and they will tell you that the majority of their patients are dealing with stress and emotional conditions. That's a big part of the problem. And it's so interesting, we could keep talking about it, but and we probably should stop at this point, but I like the fact that you actually are a psychotherapist, but you're also a nosologist, and you have come up with a new diagnosis, which is biomania. I'm not sure it's the one that we would apply to a person, but to the field, and I think that's really, really a nice way to frame it, and for us to think about. And the irony is, it's a great irony, that we here at the Menninger Clinic carry out psychotherapy intensively, and we see the results of the whole full spectrum of treatment. A big part of it is psychotherapy, but we also know in this era of biomania and neuroscience that the psychotherapy you're doing, if it's done right and it's done long enough, changes the brain. So it's a biological treatment called psychotherapy. But it happens in the context of all kinds of events in one's life, and they, in fact, turn on genes. This is the field of epigenetics. It's integrated in a way that there's absolutely no other way to see it.
I think we need biomanics. We need biomanics because the neuroscience is so crucial. I mean, one thing that I've learned here the hard way is that a number of our patients are beyond the reach of psychotherapy if they don't also have medical help. And I think the greatest advances, actually, this is heretical for a psychotherapist, I think the greatest advances in our field are not going to come from psychotherapy, but rather from neuroscience. So my view is the patients and us therapists need all the help we can get.
Yeah. I'm not going to argue with you about that. Well, we're going to have to stop. Thank you, John. This was great fun.
It was a pleasure.
And I enjoyed it, and I think it's really an interesting discussion.
Yeah.
And thank you all for joining us once again, and we'll see you next time.